Awesome, awesome. Thank you, Dr. Kramer, for the intro. So everything Dr. Kramer said, NSU PI graduate, 2018, member of the ASQ board. And also I have my CAPM in project management. So Hervé, I'm not quite at the PMP level, but I hope to get there pretty soon.
You will.
Yeah, thank you. I'm doing the presentation today on lean healthcare. My background is actually in medical education. I spent about 10 years working in graduate medical education, working with about 1,000 doctors, helped graduate about 2,000 medical students. And I knew after I got my MBA, what I wanted to do was just help them. I helped them when they were students, and I wanted to help them make their own private practice so they could practice medicine the way they wanted. So now that dream is a reality. So I'm going to share my screen and get us started. Okay, presentation mode. Awesome. Okay, so my presentation is going to be a little bit different from what you might see other people do lean healthcare. I actually wish one of our members who works at Baptist Health could join us. So I'll begin with just what the foundations of lean is, how you normally see it in a hospital setting, and then my bread and butter, which is the small practice clinic. So small practice clinics, they may have as, many as 30 physicians or just be one physician, period. It's very different from hospitals, and it's frankly where I like to be. And then some of the tools in action. And if any of you have any questions throughout, just ask. There's only 8 of us here, so dialogue is definitely something I enjoy a little bit more. Okay, so what is lean healthcare? Well, really, there are 3 types of improvement methods in healthcare. The first is lean, which is all about efficiency and flow. It's really popular in healthcare because the projects are really short. They're anywhere from a day to a week. So they can knock out a lot really quickly. The other is Six Sigma. They tend to be a little bit longer, anywhere from 2 to 6 months, very much data driven, requires additional resources. You need people to do data analysis. And the one that I see the most is Model for Improvement, which is just their word for Plan, Do, Study, Act. The DEMI model, Plan, Do, Check, Act, Plan, Do, Study, Act. So I have an idea. Okay, try it out. Did it work? Great. Continue to do it. So this is the focus on lean, which is on waste elimination and improvements to flow. So a third-year medical resident sent this to me, and we had a laugh. He says, Kara, the majority of the time I just waste my time. So he showed me this. I got to fix my orders. Well, why do you have to fix your orders? What was wrong with them? I have to log my hours. Well, why isn't that automated? Just all of this stuff. He jokes in a 10-hour day, he does maybe 1 hour of actual medicine. Can you imagine? Imagine an actual physician. They're making $250,000 a year, and they're only spending 1 hour doing actual value-added medicine. It's incredible. There's just so much complexity and waste and over compliance and regulation. It's just so much. So when I talk to doctors, the first thing I ask them, what do you need help with? And they say, we need help to our workflow. It's just ridiculous. So the whole point really is to work on efficiencies, dealing with poor workflows, rework the amount of mistakes that are there. The whole point in healthcare is just to provide high quality, safe, and effective care. So this is what the ASQ says on it. Lean methods, same thing, increase efficiency, lower costs, streamline processes, improve patient outcomes and satisfaction. However, when I call people, when I started my business, and I've been in business for about 3 years now, started just before COVID, I went and I surveyed everyone to see if this was a good idea. And so I got 3 answers when I asked them, are you interested in lean healthcare? The first answer was, yeah, Kara, I love it. I can't wait to do it. That's awesome. The second answer was, I've never heard of that. What are you talking about? And then the third answer is, lean is a dirty word. Don't you ever say that in front of me ever again. So I asked him about that. And so lean was actually really popular. Lean healthcare, the term lean healthcare was really popular about 10 years ago. And everyone caught on the bandwagon. And what ended up happening is a lot of, high-level CEOs, they're like, yeah, we got to do this lean thing. Well, they did it the wrong way. They, were like, oh, lean, we'll just do more. That's all that is. We're going to cut these budgets. Why? Because it's lean. So sometimes lean is not the appropriate word. So you'll see these other words come. And actually, these are much better words to use, in my opinion, because they're more of umbrella terms. So when you talk about continuous improvement, process improvement, organizational excellence, lean kind of falls under that umbrella. So you can have your lean, your Six Sigma, your model for improvement, all under these umbrella terms. So if someone's like, I've never heard of lean healthcare, you say, well, what about rapid improvement projects? I'm like, oh yeah, I know that one. You know, it's like, you know, we spend an afternoon doing something really cool and it's done and it's awesome. So these are, if anyone's interested in healthcare, use one of these words and someone may know what you're talking about. So here's the core concepts of lean healthcare. The number one most important thing that even the ones that I see trying to do process improvement, even though they're not too sure how, is they have to follow true north. What that is the whole point in healthcare is to deliver high quality, safe, and effective patient care. If you're doing anything that doesn't support that, it could technically be waste. And I've seen some doctors do this, especially dentists. They're like, oh, I learned this new cool lean thing, I'm going to do it. And then they're like, well, it didn't really impact our operations that much. It was cool. And then no one starts doing it after a while. The second is waste elimination. You know, it's decreasing anything that's non-value added. You know, these are the 8 forms of waste. It could be, you know, why is a doctor walking all the way from here, 500 steps to the next room and back and forth? You know, they put these little like trackers on these doctors and they find that they may work, you know, they may walk around 5-6 miles in one day. And that's a doctor, not even a lab tech. Actually, one case study showed after they did a Kanban improvement on an inventory room, they were able to give the nurses back an hour and 8 minutes of their life. That's just less walking. So it's just waste like that. Workflow improvements. If you talk to any doctor, they're going to say streamline anything that is repetitive and low touch. Stay out of my exam room. So anything that supports the patient getting into the exam room and making sure the doctor is in the exam room with everything he needs uninterrupted, that is where we look to improve it. We don't say, hey, you need to ask this question quicker, or, you know, don't ask that question, just go to the next thing. That's not where you want to streamline. That's where the value added is in that patient visit. It's all of these supporting things that need to be improved. And the last major focus is that everyone does lean, and this is especially true in the hospitals. It really is the frontline workers. They have that moment, you know, the light bulb moment goes off and they're like, I bet I could do something different. And that's where lean really begins. What lean healthcare is it's not cost cutting. You know, again, it was around 2015 where the word started to get a bad rep. It's not about overworking existing staff. One of my first jobs when I first started, they're like, Kara, we want it really lean around here. And I was like, oh my God, that's awesome. I love lean. This is going to be great. What they really meant to say is they want me to do the work of 3 people. And that's what they consider lean. So I didn't like that. It's also not putting speed before quality. You know, don't cut corners. Again, quality comes first. It's getting rid of the waste of anything that supports what is quality. And it's not necessarily a top-down approach. Really, it should be coming from the frontline workers, just like the Toyota production system. Frontline worker has an idea. They go to someone who is trained as a facilitator, which should be their managers or even a lean improvement specialist. Every hospital has one, to go and try and figure it out. So that's that. One of my favorite examples is actually over in Seattle, where Dr. Kramer just was. This is Virginia Mason, and they use the Virginia Mason Production Center. They've been doing it for actually 20 years now as of May. So it's their 20-year anniversary of doing it. And here's just a few things that they have done. And they've done over 30,000 rapid improvement projects under lean. Kind of like city furniture that we saw. Someone had the bright idea to say, why don't we just change our layout to do this expansion? And because of that, they had a cost avoidance of $11 million. Sorry if you hear any lightning in the background. They had a cost avoidance of $11 million. They did not have to build any new buildings, get any new permits. They just rearranged it and it just worked perfectly. Or even the lab test results. They were able to do a value stream map and figure out where the waste is. So that means that these doctors, nurses, medical providers, they are all getting these lab test results back 85% faster. So less mistakes, they're getting the information they need. The patients are able to get out of the hospital a lot faster. And you can see in here, reduce walking distance by 60 miles per day just by changing their layout. So this is what the everybody does lean. So on the left-hand side, that's the traditional, you know, it's top-down approach. You know, senior leaders, they have an idea and managers go do this idea, and frontline workers, you need to do it, otherwise we'll fire you, or whatever it may be. Lean is kind of the opposite. So the frontline worker has a really good idea. They take it to the manager and supervisor, and senior management is the one that needs to support them in order to get this done. So the frontline workers are really the ones who are empowered to make it happen. So here's an example of that. This is at IU Goshen. They've been doing this since 1998, and they've already had $35 million in cost savings. And it's these little tiny projects. So one, it was a nurse educator. She's like, we can just change the napkin type. This is lean. It's tiny little things, but this is lean. That saved $4,000 a year. Another one, they saved $22,000 a year by actually getting a better piece of equipment. And then almost $500,000 saved with just a good idea. These all add up. $35 million adds up really quickly when you have a whole army of 30,000 people coming with ideas that can be implemented as little as a day up to a week. I mean, lean's just incredible. This is another good example. This one's for better quality of life. This one comes out of Mark Graven's book, Lean Hospitals. So this one, a pediatric ultrasound tech, she scans babies with a very cold transducer, and every time she does an ultrasound, the baby cries. I mean, I wouldn't want that job. Every time a baby cries when you're like, you know, treating them, I wouldn't want to go to work. I'd just make babies cry all day. Well, she went to a wedding and they had these little bubbles there. So she brought it in, gave it to the mom. Mom's filling bubbles and baby's all happy trying to get it. And it's just beautiful. You know, now there's a happy staff person. So, you know, staff turnover is going to reduce. You know, she's happy doing it. You know, happy parents, that's going to be good reviews. They're probably going to be more likely to pay their bills. You can imagine the cycle time is even better now because they're not stopping in the middle of an ultrasound to see the baby. And these are just little things that are just really good ideas. And they're not necessarily lean tools, but they're lean thinking. So what is waste from a healthcare perspective? I just gave a few examples here. We have a quick little checklist over here if you ever find yourself in a medical office or just really anywhere. You know, what does defects look like? You know, it's not a broken piece of equipment necessarily, but it could be a patient that was scheduled for the wrong location or for the wrong diagnosis. It could be paperwork errors, medication errors. I was working with one place, they had saved $500,000 just by getting a team together, looking at how they do their medications. You know, how many of them are on name brand drugs versus generic. You know, they just look at these things and they figure it out. Inventory, 5S is really huge, especially in the stock rooms. You'll have so many nurses who are just like, oh, I need that. So they'll just put it in their pocket and just walk away from it. And then they have out of stocks, not knowing why. It's crazy. And then waiting is the absolute worst in healthcare. By far, the worst wait is when they have to stay in the hospital an extra day. If you stay in the hospital an extra day, it's over $10,000 per day. I think last time I saw the number, it was $12,000 is what it costs for length of stay. And that's how much it costs the hospital, the patient, depending on their insurance. And that's even if they pay. The longer you're in the hospital, the more chances are you can get a bacterial infection. Just the quicker you can get them out of the hospital while giving high quality, safe and effective care, the better. So this is just an example of what a rapid improvement project looks like. So these are these quick hit projects, generally 1 week or less. In hospitals, you see these a lot more because they do have the ability to pull in staff for coverage. So day one, they actually explain what lean is. That's how quick it is. You can just give them like a 4-hour lecture or a 1-hour workshop saying, hey, this is what we're going to do. And they understand, they can keep up. Day two, they focus on a problem. And then day three, they implement it. And of course, you can have someone, a lean expert, come back and, you know, figure out how effective it was. But I mean, it's incredible. Instead of waiting 2 to 6 months to do this huge project, they're able to do these quick little things and see results. So here's an example of one of those rapid improvement projects. It's in an inventory room. They did both a 5S and Kanban replacement. So it's really cool. They have these bins. So you can even see behind in this one, there's actually a bin behind that. So as soon as the first bin is empty, they'll just put it up on the top where someone can find it and just push the next one through. So whoever's coming to do that replenishment, they're just like, they'll just scan it and be like, okay, we need a whole new case of this. So they're not picking through going, oh, we have 3 of these, we have 2 of this. They're just like, yeah, just order another case. I mean, it's so simple. It saves so much time. They can find it really quickly. Doing this one project alone can save a hospital $500,000. I mean, it's crazy. There's so many departments, so many different floors, and they all have their inventory. But however, I don't really work in hospitals. It's not my area. I do the small clinics. Lean, you don't really see too much in small clinics. Frankly, they can't afford a facilitator to teach them. And when they do these projects, they're not getting as big of a return. There's no economies of scale. They're not having 30,000 people come up with an idea. That same project done in a small clinic only save $5,000 per year. They may say, is it even worth it? Well, in small clinics, it's not necessarily the cost savings, it's the time savings. So, and this one, they had a medical assistant who, she does all the intake, she's taking history, she's inputting if they're diabetic, when's the last time you coughed, blah, blah, blah. She would spend 2 to 3 hours per week doing this. And, she didn't want to do it. And she got it down to 20 minutes by doing this 2-bin Kanban system, simple barcode it. It's extraordinary. And it's 20 minutes and she's ordering 3 times more often, meaning they're not having these out of stocks. The doctor's not looking for something and saying, where is it? Oh, you have to wait another week. It'll be in the next shipment. These are just like really simple things that people can do. But in the small practice setting, the real main focus is on wait times. Why? Because patients switch doctors like crazy. I had one out in Seattle. It was only the month of May. And he had a patient say, you're the 4th doctor I've seen this year. So he's seeing like a new doctor every year, and it's for the same issue. So what does the research say? Well, if there's a long wait time and they even like their doctor, 1 in 5 people are just not going to come back to the office. If they don't like the doctor and they wait a long time, half of them are just never going to come back. They switch these doctors like crazy. They don't build a rapport with them. There's no continuity of care. It's terrible. And actually found that, even the rating system, which brings in new patients, they're like, okay, if it's a short wait time, chances are they gave them 5 stars, whereas 1. And I mean, I don't know what to think about it. I put down here a review from a doctor's office over where I live, and 2 hours waiting is ridiculous. It's just crazy. Oh, not to mention, a new patient visit is twice as long as a returning patient. So in terms from a profitability standpoint, they're making half as less money. When it takes 30 minutes to see a new patient and 15 minutes to see a returning patient, they can see a patient twice as much. It's crazy. So here's an issue I'm dealing with right now, and this is real life. I have someone out on the West Coast, and they really love process improvement. They just don't know how to do it. And they're having this issue with wait times. Right now they have a 2.3 star rating on Google. They're calling out his name, saying he's the slowest doctor ever. I mean, it's really hurtful. So he had this idea. He's like, you know what? I bet it's that part, process steps. He's like, it's the MA's fault. I just know it. So he went and got his little stopwatch and he measured it, and he actually found out that they're the most efficient thing that, he's just like, oh crap. So his gut instinct was wrong on that. So this is what we're doing right now. And this isn't our data. The proper way to do it, instead of just blaming, is to do a value stream map. For those of you who don't know, value stream map is very similar to a process flow, but we add in how much of it is value added time and how much is waiting. So here, if I were to put this in front of him and say, what is going on right here? You're doing great right here. I don't know why there's a 10-minute wait. We can look into that, but what is happening right here in this exam process? What is happening that half of the time it's not working out? So what we do is we narrow in on what that exam process is and take a more granular level. So we say, all right, let's keep it simple. 4 process steps. Okay, so the doctor, he comes out of one exam room and needs to go into the next. And he says hi to the patient and does their history and physical. Okay, so you get someone to watch and observe. And you got their little checklist and the stopwatch, and you record about 10 to 30 observations, and you just fill in the information. So here, on that first step, there's a range of 2 to 7 minutes. Best of time, they're taking 2 minutes to do it. Worst of time, they're taking 7. That's 5 minutes of potential improvement right there. So what is happening? And you can see FTQ, that means first time quality. They're only hitting that 2-minute mark 33% of the time. I mean, that's a huge place. So that's a red flag. We need to look at what's going on here. So that person who is observing and watching with their lean eye, they're saying, well, I see that the doctor's getting interrupted. People are coming to him with questions during this time. He may not want it, but he's getting it. Also, if we look back, the Vitaling process was really quick, 3 minutes in and out. that doctor, he already has 3 patients in the room. Just, which patient do I go to next? So he doesn't really know. He's taking a moment. He's like, quick one, long one. I'm just going to go into this room. So some patients may be waiting longer than others just because there's no focus. And this continues on. I wouldn't bat an eyelash at this one, 2 to 3 minutes, whatever. They're doing it right 90% of the time. There's room for improvement. Patient on cell phone, maybe you put up a sign or something, but where are you going to focus your efforts? 33% is a good place to look. Also here, if they're only getting it right 60% of the time, what does that mean for the quality? There's a time when the patient goes in and it's actually, I don't need to see you. You need to go see someone else. That is terrible. So it's just these little things, 75%. But with our Lean Six Sigma eye, what we do is we go in and we say, well, where are we going to have the biggest impact? Where is it the most felt? This one doctor, he thought it was, the vitaling, and he was wrong. It was doing really well. They're actually getting it like 90% of the time. So why are you focusing your effort there? Just because you notice that 10% doesn't mean that that's where the issue is. So really you want to narrow in and take a granular look. Every one of these FTQ observations is a potential lean project. You figure it out. You get the office together. Hey, this is what's going on. What's your idea? Allow the little light bulb moments to go off and just work together. So, interrupted with a question or phone call, just talk it out. Make him a new process. So here are the other common causes I had. So, and these are terrible, I know, but the front desk, they actually had like 4 patients waiting and they just never talked to any of them. So they were just there waiting. The doctor, he had been there for 40 minutes and hadn't seen a single patient, and he was just wondering why. So front desk, that's one of the areas. Another one was the bottleneck. I talked to the doctor and she said she spent half of her day on Netflix. Remind you, this is someone who's making $250,000 a year and she's spending half of her day watching Netflix. Why? The step before her was the bottleneck. It was a really slow medical assistant who, they're asking all the questions, do you have diabetes, blah, blah, blah. It took him 30 minutes to do it and it took her only 15 minutes to see the patient. So that was the bottleneck. Things with that, visit interruptions. This one happens so much. Remember, the whole point is for the doctor to have uninterrupted quality time with that patient. They are an artist. They are thinking through this. They're having their little process flow maps. If it's not this, then it's this. And when people are just barging into the room, it ruins their concentration and it doesn't look good. Imagine that on the patient reviews. You've seen them. Additionally, they may not even have a stocked room. What they love is they have their little swivvy chair. They just love to be able to just swivel over to what they need and grab it. Well, if it's not in the room, they have to run out. They have to go look for it in their messy inventory system, come back and say, oh, I'm sorry, I only have 3 more minutes with you. It's not the way that they want to practice medicine. And the worst one I've seen is just the patient was forgotten. They didn't tell them they could leave the room. So these are really common. They're not shown in the value stream map, but these are some very quick hit common things that you just see in every office. Actually, the worst one I saw was an endocrinologist. He was always 2 hours late with his patients. And the reason why is not because of the patients or their systems. They were actually really efficient. The doctor just showed up late 2 hours every day. So the solution to that, because he didn't want to change anything, was he just took phone calls from his car, seeing patients that way. Just what can you do? It's a crazy world out there. This one was actually my favorite case study because they didn't even do our normal lean value stream maps or anything. This was at Harvard, the student clinic. It took them 80 minutes for our normal patient visit. And they were like, okay, we got to do something. So on a big monitor in the middle of the room, free, they used Google Sheets, just normal spreadsheet, free, nothing. And they just had someone update every time the patient would move to the next room. Well, I mean, it was great just by visualizing the process. They were able to shave 20 minutes off from that. Their goal was to have a 60-minute total visit, and they achieved that. It actually ended up being like 61.5 minutes, but they were able to do that. So what happened? This student in this case would just look at the board and be like, oh, the patient's roomed, I gotta go. And they went in. Or, the student was taking too long, they're only supposed to have 30 minutes with the patient, and the preceptor would come interrupt them if they're taking too long. So it really got rid of all of this waste and sped up the flow. And then as they were doing it, they were doing other things like sharing best practices, like, hey, student, I see you're messing up at this. Here, use this template. So they really started encouraging each other as they were showing just how well they were doing and sharing their performance. Here are some other examples of that. So on this end at Levine Cancer Institute, they're just old fashioned using their whiteboard and sticky notes. And then over at University of Wisconsin, they actually have a software that does this. It's called OneFlow eSynchrony, and it's touchscreen and everything. They just move them right over, and it timestamps it for it. It's super awesome and really cool. And look, you see she's smiling because she's not dealing with angry patients who are waiting. So the great thing about Lean is once you solve one problem, the next problem shows up. It's really like alleviating the bottleneck and going to the next thing. So it may be that they've done everything they can with the actual, exam room process, and they're saying, well, our patients are still late. And then you start looking at layout and design. How far is it from the parking lot to the front desk room? Are they walking through a maze, or do they just come in and not get confused? The doctor not having everything he needs in the room. Is that a 5S Kanban project? It could be any number of things. So that's the great thing about Lean. As soon as you solve one problem, the next one makes it readily available. It's like, oh, this was working, now this isn't. So it's just really cool. It's very much like theory of constraints. Another one that's really good is doing spaghetti diagrams. This is how Virginia Mason was able to remove 60 miles of walking per day. This one's for a laboratory. They just saw how often they were walking and, so how do you change things? Do we change our process? Do we change our layout? So it reduces excess movements, repetitive movements, and it keeps people in the office because they don't want to be walking all over the place. Sorry. The next would be visual controls. These are some things that people do. One of my favorite things is actually footprinting. So in this case, you can see they have these little carts. If the cart isn't there, they know it's out and somebody's using it. So it's just a visual cue. It relays information in real time. They don't even have to think about it. Or imagine all the questions that are avoided about where is the bathroom because there's stripes on the floor saying where to go. It's just, it just saves so much time, and they put it in different languages. Here's an example of 5S. If you work there, can you easily tell what's missing on that cart? How about now? You can see there's just the empty space right there. You can even see what's missing. So if someone needs to order another one, they can just go ahead and grab it really quickly. So the general rule in these little small settings is if it takes more than 5 seconds to figure out, then there's a room for a Lean project there. So we can figure it out. And then these are just some other things that we use pretty often. One is waste walks. You just fill in a sheet and you get a bunch of people to do it together and you make it a lot of fun. So, an example could be motion. Why are you walking 30 steps to throw away the trash when the trash can be right next to you? The one that everyone is using right now is when you come into the doctor's office, especially for the first visit, they scan your driver's license and your insurance card. It used to be they would walk all the way to the other side of the room. And now they are just sitting, it's just right next to them on the desk, just no time wasted. They just hand it back to you immediately. I mean, it's amazing service. And procedures, we see this a lot, especially in dermatology. They'll do shadow boards, so you have everything you need all in one place. The doctor knows. He doesn't even have to look half the time because it's in its correct place. Morning huddles are becoming a bigger thing, and just even forecasting. This is especially true in family medicine where they have pediatric patients coming in just before school. They know that they need to bring in another provider to do all those wellness checks ahead of time. So these are just some of the things we see with Lean. Sorry if I sped through that a little quickly, but.
Hey, Kara, sorry to interrupt.
Hey, Kevin.
Hi, how are you doing? Can you go back to the previous slide?
This one?
Yeah, I see you have GPS tape.
Oh yeah, GPS tape. Sorry, I didn't mention that one. So GPS tape is just what it looks like. It's tape with a color on it. So how this is good is, let's say exam room 1, everything there is, has a green GPS tape on it, a thermometer, blood pressure, whatever it may be, instruments. But then you go in exam room 2 and everything's purple. You can clearly see if something's out of place. I actually saw this, and I don't mean to call them out, but Cleveland Clinic could really use this in one of their exam rooms. No one can find they have a vitals cart that they move around. GPS tape would be very helpful for them to be able to locate these things because, exam room 3 has 3 instruments and exam room 2 doesn't have a single one. It's like, well, you got blue and pink and purple here. It doesn't belong. We'll put it back where it belongs. You're being lazy.
Interesting. Okay, thank you. I was just curious about that.
Yeah, no, GPS tape is really awesome. So I couldn't find one in healthcare. I got to take my own picture, I guess. But that would definitely be the place to do it.
Okay.
Yeah, we definitely did that whenever I was in the company in Houston. We had like 3 different workstations and we were losing tools all the time. And we're like, we can't find them. Where are they? So then finally I would put tape around each of them and then you could find the culprits very easily.
Yeah. There's one I haven't put in here yet, and I can't wait to do this project. There just isn't a need for it yet, but it's kind of like a grocery store wall. So instead of going into the inventory room, you just have like a plain wall and you just put the most common items on that wall. So, let's say the gloves or something, you need a new box. Instead of walking all the way over there, they just grab it from like this wall. I mean, it's just really cool. And again, it's just the most common items. They still have to go in the back for the 80% of items that they don't use that often. But yeah, that's lean healthcare in a nutshell. They're quick projects. It's all about getting rid of the waste so the doctors can actually do their job. Especially in these small practices, everyone cares about wait times. It's ridiculous. No one likes to wait. They will leave the minute they have to wait more than 15 minutes in a lot of cases. There's my info. Any questions? Oh, sorry, I see here. There are 8 ways. You identified 7. Yep, so this is actually a checklist. It's from the book Lean Doctors. They don't talk about non-utilized talent, but really that's kind of the purpose of lean. It's actually use that talent. You have a great idea, go ahead and do it. Another example of that is during COVID, what happened was there was a shortage of medical assistants. So they actually were asking these residents who are highly trained, they've already completed medical school, many of them have had 2 to 3 years of extra training, and they were asking them to sweep the floors. That's not a good use of them. That was not a good use of them. So that could kind of fall into non-utilized talent as well, or just wrong use of talent. That'd be a waste, especially during COVID. There wasn't enough doctors.
Yeah, so Kara, the reason I'm telling you 8 types of waste, because you remember with an acronym called downtime. D is for defect, O is for overproduction, W is for waiting, N is for not use, meaning somebody is capable, but you don't use that expertise very properly. That's a waste. So that's also one type of waste you
they can update.
Take out in the lean process. So that's how we remember downtime.
Yeah, but that one can be updated. I haven't made my own form yet. It's an eventual improvement project.
Yeah, but this one I learned from one of my Lean Six Sigma, program at FIU. So that's what they used.
Yeah, thank you.
You're welcome.
I thought this was great, Kara. I really appreciate it. I think maybe the concept of waiting, because it's ubiquitous, everyone hates wait. And I would also argue that right now, most firms are really concerned with capacity management because they can't get people. And so maybe that's a good entry point for project acceptance, saying, maybe we can help with capacity by eliminating wait within our own. So we free up our own time. So we're not so stretched. So we don't start doing stupid things like getting doctors to sweep the floors. But maybe that's, because sometimes it's, where do you start? And again, I appreciate you talking about the prioritizing, Pareto it out, go for the one that has a good bang. But yeah, even within that, so what do you think? Do you think waiting, think to Rusty, does waiting seems to be a great.
It's highly visual. If you have 5 patients in the waiting room, I mean, you can tell 5 versus 1 person waiting.
Yeah, I just about told my audiologist. Oh, I did tell my audiologist. She didn't show up for I was there before, before my appointment time. Big surprise, and she wasn't there until after 30 minutes, and her staff didn't even tell me she was delayed or why. I'm like, if this ever happens again, you'll never see me again.
Yeah, a lot of it.
I said, this is totally unprofessional. You knew why, and you didn't give me the professional courtesy to tell me what was going on, to let me I could have said, okay, no problem. Or I could have said, no, I got to go. We have to reschedule. No, you just assumed that was acceptable. So you just totally wiped me out. You just totally, and that's ridiculous. So, I think we have to, we got to keep people accountable and actually, and treat each other as professionals. And it seems like service industries like South Florida, geez. And especially in healthcare, this seems to be a common thread, people, the delay times are just ridiculous. And we're all compassionate, but as customers, rarely do I feel like I'm ever allowed to know what the hell's going on. And I don't mean the root cause. I'm just saying that there's a delay. What's the expected time of delay? And given an option, what I want to do about it. I'm not trying to ask them to justify a delay. Just tell me that they're running X minutes late. Even that, it's crazy.
So one of the major reasons for that is training. One of the biggest problems that these small practices have is keeping someone at the front desk, someone to manage and just basically be the presence for the whole office. They're having trouble keeping them for longer than 3 months at a time. So they don't know what is acceptable, what's not acceptable. And actually one of the lean things to do is, it's kind of boring, but roles and responsibilities, SOPs, they make a huge difference, especially when there's such high turnover like that. Having the information recorded, especially the little visual ones, 3 second. One office, it was a one practitioner. They had their ultrasound tech coming in and checking in patients, and she knew how to do it because it was documented. No other ultrasound tech knows how to do that, but because, it's like, okay, you do this, this, and this, she was able to fill in, cross-training, just, you can help fill in, be a floater.
Other comments, observations? What do you think?
Yeah, I had one. So I noticed that you talked a little bit more about like some of the smaller, quicker projects, like lower hanging fruit. So how did you balance like picking something like that would be an easy fix versus something that might entail a little bit more work, but have a bigger impact, I guess?
Right. So usually for at least the people that I work with, this is their first introduction to lean. A lot of them, this is their first practice. They've only been open, a year, maybe 2. And it's really just about firefighting and getting them to a point where they can breathe. One project that we're actually going to start right now, it's more of a Lean Six Sigma project, but they were looking at how the residents were entering the medical errors, and they found out there was about 99% of them had a defect on them. 99% of these forms have a defect on them. They're not all defective, but there's a quality issue. And when we actually, I'm sure when we look at the data, we're going to see all these quality issues that come as a result of that. Are people leaving because their medication wasn't inputted correctly? Are people dying? These are much bigger things. But where I'm at right now is we're doing a lot of quick hit projects, and we like them. And a lot of it is because these doctors don't have coverage. They don't have time to be taken out a full day or even half a day.
I have a question. Do the physicians get involved with these projects frequently ever?
Yeah.
That's because I think there's always a concern. It's almost like, I don't have time to fight the fire because it's burning me up. It's one of those things is, how do you get those physicians to be part of these events?
For me, I only go after physicians who want to do it. You can call that low hanging fruit, but I want to help the people who are ready to help.
Yeah.
And you can't do it without the physician because they are the lead of the office.
So how much of their time would you say let's say a week event would require from the physician, away from, let's say, applied patient time, productive, quote, productive time?
20 minutes a week.
Yeah, see, I
Honestly,
don't think they don't understand that probably. It's like, no, we need to be involved, but I'm only looking for 20 minutes.
Yeah, they actually aren't the ones who do the work. They're the ones who are setting the direction. This is the problem I have. This is what I want it to be. But they're not the ones who are taking the time. It'll be a medical assistant, a medical student. In some cases, it's a family member coming in to help with these types of things, because they just want to keep things going. Or sometimes it's during a no-show, which, they may get 3 or 4 no-shows a day. So there's some downtime there for them to catch up. But the doctors aren't usually the ones, they're living their life normally. It's all of the support staff who are filling in the roles, doing the data collection, making the
Yeah,
change.
'cause you said that before. You said you're not trying to reduce the time it takes to do the health application. You're trying to reduce the waste that surrounds it to
Yeah.
enable them. You're assuming, and it's kind of like, you're assuming that their step is effective and efficient. And you'll take it at that. It's like when we look at a normal, only 20% of a lead time or 2% lead time is normally value added time. The same thing here, that 2% still may be full of waste. But if you get rid of all this waiting time where nothing's happening, you're still so much further ahead. So you don't really have to go after the inefficiencies of the inherent processes that the doctor may be using, and they may be horribly inefficient. But from the patient's point of view, at least they're with the doc while that's happening. So it's more psychological, unless they feel like he or she's a bumbling idiot, and then that's an issue. But
Actually, that's a huge problem that has come up. So this happens more often than I would like. So an example is a new patient comes in and they, are talking to the doctor. It's a 30-minute visit, not a 15-minute visit, because it's a new patient. And they say, actually, I don't think you're the right doctor for me. And COVID's been huge on this because you have the conventional doctors versus the naturopaths. It's like this, we're divided right now. So that doctor just wasted 30 minutes plus all of the support things of, checking in, getting the insurance, calling, all of that. And they say, I'm not going to come back. That's a lean project right there. You can combine that with marketing, saying I am a, conventional doctor, these are the types of things I love versus, another doctor who's like, I'll prescribe this instead. So it's also just matching up the right doctor with the right patient, because patient nutrition is probably the worst thing for lean. Just the fact that it takes twice as long to see a new patient and it costs money to acquire them. That's huge.
So I don't know if you had already touched on this. I came in a little late, so I apologize. But so you come into a practice, right? And you see all this stuff going on. How do you go about trying to identify, okay, this is an issue, this is an issue, and this is an issue, so that way you can start analyzing potential issues as to what you want to move forward with?
Right now, I've seen it fall into 1 of 2 categories. One is they are very focused. They know exactly what they want to do, and so that's what we're going to do. And then the other is the unfocused, where it's I take some inspiration from Scrum Agile and I say, make a list. And then we do our little data management stuff where we find a way to prioritize it, give it a number and kind of like a risk priority number, but not. And that's where we start. So it could be points. And one example is quality points, not quality points, but effort. So we may say, oh, it's like 6 points worth of effort. Do you want to do 6 1-point projects, or do you want to do 1 6-point project? How much time it could be. So I'm starting to try out with that one. I don't know quite how it works yet, so I need more experience, but we're trying to figure that one out with time estimates. So backlogs.
What would you say some of the strengths and some of the weaknesses are with applying lean potentially in small practices?
The strength is that it's very quick. A consultant once told me that, big corporations have the same problems as little ones, only it's just more complex because they're so big. So it's very, you want to change something, the doctor says it's a one person and it's changed. There's no, these layers aren't there. These approval flows aren't there. They're there when they're attached to a bigger company, but I work with the small private and, practice ones, they own the practice. So that's definitely the biggest advantage is the decision makers there. And they say, do it, and they do it. However, the downside is when they're not the ones doing these projects and their staff who already think that they're underpaid and underappreciated and that you're just trying to kick them out of this job, replace them with your efficiency. And why are you cross-training this person on my job? It's a lot of people management skills there. And that could be very challenging, especially when they're ready to quit at a moment's notice.
Kara, I've had a personal experience in small practices and where I was trying to establish some lean principle and all that. One of the things that I kept running into was oh, it's not allowed because of regulatory issue, or we can't do this because of regulatory issue. Have you encountered that as well?
I thankfully haven't too much. The doctor has pretty much safeguarded me from a lot of those. You know, we have a quick, he's like, no, we're not doing that. I've been thankfully able to keep it placed into just these, you know, these process oriented things where we're not saying, okay, you know, you still need to scan their insurance. That's still happening. So I think we haven't had to deal with that.
So it's not a compliance issue if I read into that, that they're really focusing or facing as much as an efficiency issue. Is that what I hear?
There are some compliance things. I mean, I've asked the question plenty of times and it was, you know, just my own education. I was like, well, why don't you see the patient for multiple things in the same day? They only see a patient once. You know, in my mind, every time that you schedule the patient to come back, and it's not for follow-up reasons, it's for a completely different reason. You know, 1 month, you know, one visit they want birth control, and the next they want blood work, and you know, so on. Because every time they do that, they're calling the patient in, they're losing the capacity to bring in another patient. So I asked them about that, and that comes down to a medical billing issue. So there are certain things that I'm running into. You know, that's a lean thinking thing. You know, you can remove 6 process steps just by keeping them there on the presence. So that's more with family practice. With procedural based things like osteopathic medicine, they're able to see a patient for loads of things and load up that bill and give them tons of value. One of them had a 3-hour visit. I was like, oh my God, that's great. They had everything they needed in one visit because it wasn't the traditional, you know, just normal annual visit type thing.
What else? Anything else?
Thank you for having me on, Dr. Kramer.
Oh, no, thank you. This was wonderful. We appreciate your coming and supporting our student branch meeting, you know, all this stuff. So it's all good, you know, and I'm glad that we have a wonderful mixture of students and senior folks here from a variety of places. You know, it's not a huge crowd, but it's a good crowd. And I think that's more important, you know, quality over quantity. So I appreciate you because I think everyone here has learned a lot from you. I know I have. And so we really appreciate your time, and we always love your energy, you know, so that's an awesome thing. So we all need each other because we all need your energy. We all need each other's energy. So I want to encourage everyone to help each other, keep plodding away and learning and encouraging and, you know, risking failure here and there because you're still trying hard, knowing that we got your back somehow. Yeah, well, that's great. Okay, well, thank you all for coming. This was recorded, and the link for the recording will be on the LinkedIn group, both in the 1510 as well as the student branch. And again, please tell your friends and neighbors that you know, we'll continue to keep having these meetings throughout the year, and they'll be notified most prominently on LinkedIn, although we'll try and get you any way we can. That we have newsletters and we'll find other ways we can get to you. But so thanks for coming. And by the way, of course, you're still our customer. So when you think of something that you think we could benefit from, even if you're not directly involved quality wise, bring it up, you know, whatever it is. It could be lean from this vocation, or it could be a certain tool. It could be technical writing supporting lean practice. I don't really care, but it's something that you have interest in. Probably we do too. So you know, help us. You're the customer, so tell us what you want, and so we can bring it for you. All right, wonderful. Well, everyone have a great night. It's actually almost 8 o'clock, so we're on time, and it's so wonderful to see everyone. And we'll you know, we'll let you know when we have the next in-person one. You know, with the students being essentially out more than in during our summer months, it's harder to convene them into personal like bodies. So most likely throughout the summer we'll continue, but they'll be virtual, which is fine. But then in the fall, starting, well, September, of course, we'll have our alumni event at my house. So you're all invited to that. And then October will be our next major not at my house on ground event. Okay, well, everyone have a wonderful evening. It's good to see you all. And we hope to see you soon.
Thank you.
Bye.
Thank you, Kara, for
Thanks.
speaking.
Thanks, Dr. Kramer. Thanks,
Thank
Kara.
you.
Thank you, Kara. Thank you very
Bye.
much, Kara. Bye.